Thank you so much, Maruti. It's a pleasure. It's really an honor being here with my learned colleagues in pediatrics. Thank you for having me. This is, like you said, this is a very big topic. I struggle to just find things. I haven't even presented in a very long time. So guys, bear with me. I'm going to try and make it very easy as well, understanding that I'm not presenting to fellow ENT surgeons. So I'm going to try by all means to summarize and simplify it. I hope that it will be fun, and hopefully by the end of it, you will have, you'll understand more, or at least feel happy that you attended this. So yeah, Marty, as you share those pictures there, you can just roll them. This is not where I am currently, but basically this is where I spent my year of clinical fellowship. This is called Starship Children's Hospital. It's in Auckland, New Zealand. And I mean, really, when I left the country for this fellowship, I had lots of questions. I did not even know how much scope of practice I'll have to do, but it was all worth it. I don't think that a year is enough to do a clinical fellowship in pediatric airway surgery, but for all it's worth, spending time in this place got to give me an approach to pediatric ENT, particularly airway, and I'm really grateful for the opportunity that this country also gave to me. So the outline of my presentation is definitions. I'll keep it simple. I'll go through some classifications, a bit of prevalence, approach to diagnosis, an overview on surgical options. Then we'll talk about when you pediatricians can refer to us, and that should be it. So this first slide, as you can see, is basically showing you my scope of practice. I don't think it's a perfect picture. You know, I hope that it gets to where I believe my scope of practice is, but the upper airway for me as a pediatric airway surgeon is from the tip of the nose to the carina. We all know that the carina is where the bronchi split. So assessing airway for us actually starts from the tip of the nose to the carina. Stertor is a noisy breathing that sounds like snoring, usually caused by a partial obstruction of the upper airways at the level of the nasopharynx and the pharynx. So that blue color on the picture basically shows you where you are most likely to have an obstruction, partial or complete, that will give you a noisy breathing like a snoring while you are not sleeping. Stridor would probably be represented by those two colors, red and orange. Of course, there's wheezing on orange as well, but stridor is actually a high-pitched, squeaking sound, usually due to an obstruction, also due to an obstruction, partial or complete of an airway. It is a sign of an underlying issue rather than the diagnosis. It's obviously more common in children because they've got narrow airways. We know that we categorize it into three. Either a child would be having an inspiratory stridor, meaning that it occurs when they breathe in, and of course that red showing you the level of inspiratory stridor, often from the supraglottis to just below the cords, and the expiratory one is when they breathe out, when they're having this high-pitched sound, and you find that it's from the tracheal level down. Sometimes it is biphasic, where when it happens when the child breathes in and out, and that can actually really be transglottic all the way to the carina. You do have wheezes involved in this as well. You know more about wheezes than me. Classification is quite broad, and everybody has their own way of classifying things. You know, there are people who believe in congenital versus acquired. Other people say structural versus mechanical, or you can combine all of them and just do, as long as you understand what at the point you are referring to. And I just threw in a lot of differential diagnosis, or rather, what could be congenital and what could be acquired. And as you can see there, you all know, I mean, we always get consults from pediatricians about recurrent choanal atresia or stenosis. I'm just taking it from the tip of the nose. Of course, I'm really going to, there's a lot. This is like a tip of an ocean of the differential diagnosis you can get congenitally from the nose considering there's the tip of the nose, the mid-nasal, the choana, all that, you know. So I'm just choosing choanal atresia being very common, or stenosis. LM is laryngomalacia, TM tracheomalacia, BM bronchomalacia. You could have vocal cord palsy, unilateral or bilateral, laryngeal clefts, laryngeal webs, subglottic stenosis, tracheoesophageal fistulas, vascular lesion, and so forth. And when it comes to acquired, that's when a child would be having an infectious cause. Most of them come with epiglottitis, viral infections like croup, tracheitis. Neck abscess can also cause upper airway obstruction, and etc. You can have trauma, be it blunt or penetrating. Intubation is very common in these ventilated kids with trauma to the posterior posterior cricoid, and the inhaled fires, very typical of causing adhesions and trauma in the airway and neoplasia. So you've got structural. You can also classify it as structural, saying where this diagnosis is, whether it's in the nasal level, pharyngeal, oral level, and you can have mechanical as well. There are people who prefer to say, is it intrathoracic or extrathoracic, or rather intraluminal versus extraluminal. So really, it's just throwing a whole lot of differentials out there. And according to Monier, the prevalence of congenital laryngeal, just laryngeal anomalies, not mentioning nasal, pharyngeal, or tracheal. We've got laryngomalacia at the top of the list, meaning that when a baby presents with stridor, more often it is laryngomalacia according to this, followed by vocal cord paralysis, understanding that, you know, most of this, actually, I think with unilateral being more common than bilateral, and with unilateral very positional, it's not as severe as bilateral, and it could be from even trauma from birth trauma, you know, just prolonged labor with use of forceps and all that. So you can imagine how many women out there are going through traumatic deliveries, and therefore it probably ranks higher as well. I mean, there is a lot bilateral being caused by central issues and so forth. Subglottic stenosis coming third, webs and atresia. You can have subglottic hemangiomas, cysts, and then clefts at the bottom there. So, I mean, it's just to really throw diagnosis and what we think comes first. Now, talking about the approach to diagnosis, like we say, this is a very big topic. I cannot really go into an approach when this child is in emergency room, okay? That's a completely different approach. And I think with that, you've got a child who's in severe distress, exhausted, their heart rate is dropping, their respiratory rate is dropping, they cannot feed, they cannot play, they are just anxious. There is not much to do, no time for history taking, no time for scopes and whatnot. So we do, usually the pediatricians, trauma unit, anesthetist, even when they call us, you find that this child is already intubated. So really it all depends on at what level you find this child in their grading of respiratory distress. But I think this approach would work best for patients who come to my rooms. And again, it's not always where you find that the child comes to the rooms with respiratory distress. So it could be a history given, but just for the interest of things, my first approach is observing a child. My room is actually very child-friendly, and I think I did on purpose, because you don't want a table in between. You just want the child to be happy and free to just crawl on the carpet. Parents are that side, and you know, so you can be able to see the child and observe the behavior and all. Because with airway, observation is very key. Again, if you're going to assess the degree of distress, let's say this child is distressed at the time, you're looking at whether they are grade 1, 2, or 3, and looking at their noisy breathing. A child who's still having noisy breathing with some mild dyspnea, not anxious, can still take some food and drinks and interested to play, would be your grade 1 distress. and a child with severe dyspnea, not interested to play, anxious, refusing food would be your grade 2. So this is a child who's even having energy to refuse food, saying, I don't want to play, not interested. But a severe child is a child who's exhausted. They usually don't have stridor. Their parameters are just dropping. They've got this ashy color on the skin. And you know, with that child, this child can decompensate very easily. That's when we move very fast. So I look at that. And again, I like to look at, you know, the dysmorphic features of a child, whether, you know, the size and the position of their mandible and the tongue. You're looking at the behavior, how they behave to the parents. You know, I mean, this is not about hearing and all that, but we actually just observe a whole lot on these kids while they're just around. And when it comes to medical history, intense history is very important. I think it's very important to talk about pregnancy history, perinatal, the growth, development of this child, their milestones, immunization. Very, very important, which I always stress, is allergies, the history of allergies, allergic rhinitis. I found that, you know, at this stage in my career, allergic rhinitis tends to be the core of most of the problems that kids end up with. Feeding and speech delay, sleeping pattern, particularly, you know, a history of snoring with obstructive sleep apnea. I think at some point, you know, a question of snoring with obstructive sleep apnea needs to be a baseline. Maybe the next group of medical students just need to standardize that. Some books must standardize it, because I think people don't understand how bad this can turn for children. I mean, even for adults. So asking about snoring and whether the child has obstructive sleep is very crucial. Asking about speech delays is very crucial. Recurrent infections and so forth. And if the parents, because most parents now don't sleep with their children, then you say, okay, you don't know if they've got apnea, please ask the nanny to spend the night with the child, take a video, share it with me, then you can share it with your ENT, because that, for me, often when somebody wants to refer me a patient, I say, please ask them to send me a video of that child sleeping. Make sure they expose the upper body, so that I can see all these breathing movements and sounds. That is extremely important in deciding, by the time you see this child, you've built a picture on exactly how you're going to approach them. Medical history is as important. And you know, as you dive into the presenting symptoms, you want to find out about the age of onset, whether it was from birth, shortly after birth, whether it was, you know, aggravating factors, whether there's usually recurrent infections with this stertor or stridor. Is there feeding issues with it? Is it influenced by body position? When they lie on one side, it gets better or not. When they lie prone, it gets better. All these things, there's actually an explanation to all these body positions, which can guide us to the diagnosis. And a history of prior intubation, we know, is extremely important, with a history of prior endoscopy. If the parents can share with you whether endoscopy has been done before in the room, so in theater, and what was the findings. And again, history of cardiac, thoracic, or esophageal surgery. With the presenting history of a stridor, you really want to exclude those, because that could be the reason why this child is having all that. And of course, we don't expect our colleagues to remember all this, but I guess this is why, for any child that has these stertor and stridor and you're really not sure, you just send them to an ENT. I think there is really no need to keep a child with those symptoms, you know, with yourself, because there is a lot that could be going on that we can assist, and we work together. Endoscopy is an approach to diagnosis. You know, most patients come with already, you know, the pediatricians would have done lateral neck x-rays, chest x-rays, and I have to often convince the parents, I don't force on endoscopy in the rooms, because I understand that it's not a comfortable procedure, especially if I know that I will end up taking this child to theater. Then I just plan for it in theater, and we'll talk about that just now. So nevertheless, let's go back, Marty. Nevertheless, a transnasal flexible laryngoscopy is our gold standard. As an ENT, as you can see a picture below there, there's a STORS flexible scope. a bit old-fashioned. I think there's not a latest one, but for all it's worth, that could probably be the thinnest for pediatric size as well. That's a CMAC, which shows you what you're looking at. It is our gold standard. It is an X-ray will show you, how can I say it, an opacification. But depending on the onset and all those other things you would have taken from history, you know, you cannot be sure that what you're seeing is adenoids until you do a flexible scope, which can then help you put your diagnosis in a good stand. So we use it to determine the patency of the nasal cavity, the choana, the nasopharynx, the pharyngeal larynx, and we also assess the degree of the dynamic functioning of the airway at the nasopharyngeal level. And so a lot of differential diagnosis can be made with endoscopy. Of course, from the supraglottic level, we do not let it touch the cords. We just assess just above the cords, especially if the child can tolerate it. We have to, I bought myself a tiny stethoscope while I was doing fellowship. I didn't own one for a long time after medical officer years, but it was quite, it was a must that I carry one, because then I needed to relearn how to auscultate the lungs and the heart. Of course, we are not that as good as you, so we prefer to do it when the kids are quiet. Radiological evaluation is very important. Whether it will come before or after endoscopy, after GA, really depends on what the pediatric airway surgeon feels like. Often we go for endoscopy, and whatever you see, you can decide, now I think what I see is a pulsation on endoscopy. Maybe I need to go for a CT scan, CT angio, MRI, whatever it is. Some people, depending on where you are and availability of resources, you end up booking, you know, a radiological assessment first before you scope, because whatever limitations you have. So the next approach to my diagnosis would be endoscopy under general anesthesia, and often in theater I would do what is called drug-induced sleep endoscopy. So you've got a child who's really struggling with stertor, stridor. Parents are telling that these sounds are worse when they're sleeping at night, terrible sleep patterns and all that. And it's, you're listening to the sleep videos and you can't figure out, you've scoped them. They don't have big adenoids, they don't have big tonsils. What's going on? You have to put them in a position where they are like, sleeping in theater. They're not paralyzed, they're in spontaneous breathing, and you have an anesthetist that is very good with pediatric airway as well, and that they understand the combinations that you need for this child to be in a sleep mode. And then you can use a flexible scope actually for the nasal cavities and the choana and the pharyngeal level. A flexible scope will give you the dynamic picture again. You know, you'll have to, then you assess how things are collapsing when this child is sleeping, things that you might not have done, you know, in your rooms, or maybe it was uncomfortable. You do it in a sleep pattern under GA, and you swap from a flexible to now rigid scopes, where you now assess all the way down, depending on, again, the type of stridor that you have. When you hear that it's biphasic, it's expiratory, you're like, okay, I definitely have to take you to theater, because whatever level it is, I would never see it above the cords. So it is an indication right then there that you will have to do your endoscopy far below the cords and assess what else is collapsing. Perhaps this child has tracheomalacia, bronchomalacia, a combination of all. Maybe it is a vascular ring or whatever, putting pressure. Maybe it's just the cartilage is collapsing. Maybe it is that. It could be a lot of things. And you know, so that's when we do a diagnostic laryngotracheobronchoscopy. At times we add oesophagoscopy, and I always write on the consent with or without proceed. It's proceed is 100 of things, and of course, with what the child is presenting with, I'll always consent the parents to that, and we never leave tracheostomy behind, because proceed can really mean a lot. So that's basically my approach to diagnosis. And really, indication for endoscopy under GA is based on your progression of symptoms. Sometimes associated abnormalities, other systems involved. A typical presentation, you've got this chronic stridor, the child is failing to thrive, they've got feeding difficulties, obstructive sleep apnea, core pulmonale, you name it. So you know that a clear diagnosis is warranted. And that's when we do that drug-induced and diagnostic laryngotracheobronchoscopy. And what, okay, before I get to this, Marty, sorry, because you are sharing this for me. So during endoscopy, videos and pictures are taken, and at times I discuss proceed possibilities with parents. Sometimes you see something else, and while the child is still under, you go back and you talk to the parents about it, and you decide if you're moving on or not. Sometimes really you need to wake the child up and do more investigations. That's when maybe more imaging is warranted and needed before, and then you can plan your next surgery. So the objectives of surgery are really clear. You want to remove the you know, of course, you're trying to get you've already gotten your diagnosis, I believe, from endoscopy and imaging. Now you want to remove the obstruction or widen the airway. I get consults from a pediatric pulmonologist who I think also understands the role that I play, and I think, you know, pediatric pulmonologists and pediatric airway surgeons have that bond, and I think it really makes sense that, you know, they understand that if I'm going to give this child some medication that needs to be nebulized or inhaled and whatnot, if there is an obstruction in the upper airway, there is not going to be good delivery of this treatment. So if you're giving treatment and there is no response, please look at what could be obstructing this, and perhaps sending the patient to us would help us just create a path for the treatment to go in. And sometimes it's not just creating path, but like I say, to widen the airway in our diagnosis and stuff. So yeah, I think finally on this slide here, really guys, I think there is so much I did not know. I think Prof. Shazia will probably share more on what I have missed out here, but this is just me saying proceed. When I say proceed, and I'm just going to mention about 3 things that are like quite common. So proceed being the surgical options, and this is very common. And as much as it sounds like a very common procedure, you know, adenotonsillar tonsillectomy. This for me as a pediatric ENT or pediatric airway surgeon is, I understand it deeper, and I understand how it makes life very easy for children. So I take it as serious as any other airway presentation. So if a child has stertor, they've got stridor, you assess them and you find that their lymphoid tissues are hypertrophied, they're really struggling, they have to mouth breathe, they can't cope, their turbinates are always enlarged, their adenoids are enlarged, their tonsils are enlarged, you know, you always have to resort to the surgical option once you've assessed it, whether in your rooms or in theater, and this would be almost the most obvious proceeds that you would have discussed with the parents. Understanding the issue of allergies, for me, it's always the 3. This coblation turbinoplasty, coblation adenoidectomy, and coblation intracapsular tonsillectomy. So, you know, that is like for me, not standard, but obviously with reason. What I usually do to make sure that the stertor, you know, gets to be resolved in this child. So I think this is one of the procedures that we do for mainly stertor. And I've put there a picture on the left. You can see the oropharynx, probably great. That's not the best picture to say that the tonsil is obstructing in any way, possibly just a grade 1. But we know that these kids often, when you look inside their throats and you find obstructive tonsils, grade 3 to 4 kissing, whether it's recurrent infection or not, sleep disorder, you know, that's when you're like, let me just send them. This peds ENT will take more history and see if there is a need to actually create space for this child. So that picture is just the anatomy of the orify, and it's just showing us that, you know, the difference between total tonsillectomy and a coblation intracapsular tonsillectomy. I call it tonsillotomy, and I see here the gentlemen in England are saying tonsillectomy. It's still okay. For me, tonsillotomy means that, you know, So you've got that dark blue layer. It's called the tonsil capsule, and that is basically the trick. When you remove the whole tonsil tissue with the underlying capsule, you've really removed all of it. And this is what traditionally, everybody has learned to do it this way, whether we use bipolars or we use cold steel, but this is what then causes a lot of pain and risk of bleeding. Reason being, you're exposing now the muscles. Some people are very good after removing the capsule, the muscles are intact, but sometimes there is exposure to the muscle, they bleed, you want to stop the bleeding, you're using whatever it is, and often very intense heat that then causes more damage to the deeper layer of the muscle. And this is when now pain is unbearable from a week to 2 weeks, and the kids can't eat, and then you have all these complications. Recovery to school and all that is more than 2 weeks. So with coblation intracapsular tonsillotomy, which for me is standard, and I thank my clinical fellowship time because that's all they do there. As a matter of fact, it's been put even in most articles that it's an indication for recurrent tonsillitis and for obstructive sleep apnea. So there is no worry of, can you only do it for this or that? So it's quite a comforting procedure even for parents. And if you look at the study, it's a cohort of NHS practice in England, just looking at the rate of coblation intracapsular, and more than anything, their main outcome measure was looking at the number of procedures they did, the readmission for pain, the readmission for bleeding. Those are the main complications, and their requirements for additional surgery for regrowth. So often the three things that we worry about: pain, post-op bleeding, and whether they will grow back, And their results, they operated about 5,500 kids, the mean age of 4, and within 28 days in this study, 0.3% were readmitted for pain, 0.7% with infection. Pain is usually related to that. And 1.2 were readmitted with bleeding. And in the first year, 0.3% came back with regrowth, because now you've actually melted the tonsil and left the capsule intact. Now, someone can again say, maybe you've left some tissue of tonsil inferiorly or superiorly, wherever it is, will it regrow? Now, with this study, they show that even if it regrows, in a year, we had like 0.3 out of that 5,005. Second year, 1.1%. In the third year, about 1.7. Fourth year, about 1.9. And still after 5 years, about 2.2. So really, I'm still yet to meet the parent who chooses total tonsillectomy when I tell them about the results of coblation intracapsular. And they say, no, I worry about regrowth more than they worry about pain and post-op bleed. So this is something I always encourage to say, if you can spare a child, less pain, 2 to 3 to 5 days of recovery, this would be the best option. And with surgical procedures proceeding here on this page, this is just 2 options that we also use in theater for proceed. So the top one is what we call endoscopic. So when you do proceed with whatever you've seen on endoscopy, you can then decide to do a surgical procedure endoscopically, or you do it openly. So with endoscopy, you must have all the right gadget with every. I think that the challenge with pediatrics is that with every age from a neonate to age 16, there is a different size of a telescope, of a bronchoscope, of this and that. So it becomes a very expensive business, and most places don't like to invest in that. So you have to use the right sizes. You have to suspend this child. This is a picture of suspension. This child already has a tracheostomy, so this was probably more comfortable for anesthetists. And this is microlaryngoscopy. You can actually use telescopes and do your surgery with telescopes in, or you can use a microscope. And you can do not all the procedures, but I mean, for it depends on who's done what and their level of skill, but a lot can be done with endoscopic surgery. And if whatever diagnosis is, warrants open surgery, then the picture below, basically, I think this is just an example of what we call laryngotracheal reconstruction. So having a patient presenting with stridor, and you've assessed, you've seen that the level of obstruction is at this level, there is narrowing stenosis, whatever it is, I will have to open the neck, and it is probably congenital. There is recurrent croup, definitely from the cricoid level, and now you see that, no, I need to widen this airway at this level. If you look at those yellow dotted lines, it's just to show that you will do what we call a cricoid split, the top one being the anterior cricoid split and the bottom one being posterior split. And the second picture on B shows you how we now stitch together. Okay, first we harvest a cartilage graft from the ribs, then we shape it into certain shapes for each side, different shape. You measure your stenosis and everything. I'm skipping lots of points here. And you basically place your grafts anteriorly and posterior, and that is called laryngotracheal reconstruction with cartilage grafts. And you, depending on your level of stenosis, you decide whether if you widen, anteriorly, you're getting enough space, or you need to widen both so you can get a better space. So all of that is it really depends on what you've assessed on endoscopy. And yes, this is my very last slide. And yes, we were asked to actually, talk about this. And I think, when do you refer to a pediatric ENT or pediatric airway surgeon? And to be honest, I think I've mentioned a lot of things in my presentation that already you've taken notes and highlighted. Oh, okay, now I know. Wait, Marty. Don't throw them like that. Okay, let's wait, because I'm going to start with exit. So with the first one, really this one, it's I don't know how many of you are aware of it. Exit for chaos. So exit is an ex utero intrapartum treatment, and it is used for congenital high airway obstruction syndrome. So this is usually a diagnosis made in utero with ultrasound or MRI by gynaes or gynaes with interest in fetal-maternal or fetal-maternal subspecialists who now diagnose that this child is having an obstruction, whether it's intraluminal or extraluminal, or there is atresia. This child is actually not going to be able to breathe. And we need to involve pediatric airway surgeons. We need to involve, it's a whole big team, obviously neonatologists, pediatricians and all that. And at the time of delivery, this is all planned properly, because at that stage, you actually do a procedure while the child is still connected. So after an incision and removing, delivering the head and the shoulders, before you cut the circulation of the child from the mother, separating the child from the placenta, we come with our endoscopes, we assess the airway, see the need to manage it there and there. If there is a need to put in a tracheostomy is placed at that point, because if you cut the cord, you're going to lose this child. So this is when, I'm just taking it basically from the uterine, this is when we get to be consulted with these cases. And of course, pediatricians will be in theater at that stage. So perinatally, this is whether it's a delivery room or it's cesarean section, you are called, pediatricians are always there. I believe that every pediatrician should be able to diagnose that stertor, stridor struggle, whether you're struggling to just suction the nostril. That's when we talked about choanal atresia stenosis. The child is having stridor, they're struggling with breathing and all sorts of things. So I think those two symptoms just play a part right at the time, where as you can diagnose it at the time, it's an indication for you to say, I'm going to have to consult a pediatric ENT surgeon. Of course, there's not a lot of us who did pediatric ENT in our country. So if you've got an ENT, in a hospital, they should be able to assist. In ICU, now let's say this child was struggling so much, or whatever happened from home, now this child is back in pediatric ICU, or straight from delivery to neonatal ICU, and you're struggling to intubate this child, or you've managed to intubate, you're struggling to ventilate them, or you've actually managed to intubate, you're ventilating them, now you're trying to wean them off, you're struggling. Not even struggling, but it's difficult to wean them off. Or you've actually weaned off, but after extubating, the child just decompensates or just drops again, and you have to reintubate and reintubate. So that is also failed extubation. So I think with that comes a very important need with each of those steps to say, let me call my colleagues to come and assess this child. And it is important, obviously, for us to take this child to theater to assess them endoscopically in theater and find a reason and proceed. You could be in ER, or you've admitted a child. Often it's an infectious acquired cause, and you feel like, no, these symptoms are progressing to a point where I cannot manage by myself. I think I'm not winning here. I might need to call my colleague and just to assess, if whatever I've seen is enough. And I think we should be comfortable enough to involve our colleagues quite early on, so that, just co-managing the patients with pediatric ENTs is very important, and it brings out the best outcome for the patients. Even in the wards, can I just, okay, no, I'll talk about it in the room. So let's say you are in the rooms and you're always getting this child with recurrent infections, recurrent respiratory infections. I know that otitis media with effusion is not part of this, but it becomes one of the problems, a sequel of issues when there is stertor. When there is stertor with an obstruction in the corner, possibly from huge adenoids, when there is a history of allergies, this child is possibly blocking because of allergies. The turbinates are always hypertrophied. Now with exposure to these allergies, the adenoids are always hypertrophied. Either we've got an interstitial tube dysfunction, or we have now an obstruction of drainage from the middle ear into the corner. For all it's worth, you are dealing with a child who's keeping, fluid in the middle ear. That fluid could be your worst enemy. If you don't get us involved, this is when you are going to continue treating these patients who could easily just get assessed and just drain this fluid, put in a grommet, and get the child some quality of life. And for all it's worth, everything gets better from there. And again, the child could have also presented with a stertor. So from your rooms, there is that for me would be a take-home message for my colleagues. And I think that's more about it. And yes, I think the next slide, Marty, if you just play it, it's just
yes.
It's a thank you note from me again, and that is my information. I think as consultants, especially with pediatric airway, considering that there's just 3 of us in the country at this stage, if you really not even in Gauteng, Prof. Shize is in Cape Town, and you feel like, okay, I just need to call Felicia or Prof or call Prof, just get an opinion. Feel free to do that. If you feel like, okay, maybe can I send a patient through from this province to that province? Feel free to do that. And you see where my admission rights are. You've got contacts information for my office and so forth. So